My name is Jonas Brinck. I'm an endocrinologist at the Karolinska University Hospital in Stockholm. I'm going to talk about lipoprotein A cascade screening in patients with coronary artery disease. The condition elevated lipoprotein A is a very common condition in the world. Maybe tens of millions of people are affected. And we are now talking about trying to measure lipoprotein A in everybody, but that's a huge challenge. And cascade screening would be maybe an effective method to try to pinpoint those with elevated levels. So that is why we think cascade screening can be very important. Our study had basically two aims. One was to determine the concordance of elevated lipoprotein A in plasma between index patients with coronary artery disease and their first-degree relatives and their second-degree relatives. And the second aim of the study was to try to show the effectiveness of cascade screening and see if it's good to perform or not. That was the main objectives of the study. Our two key findings were that the plasma lipoprotein A has a high concordance between index patients with coronary artery disease and first-degree relatives. 30% actually of first-degree relatives had high elevated lipoprotein A if also the index patient had it, and 20% of second-degree relatives. So the concordance was very high. The second result that we had was that the effectiveness of cascade screening is very good. You can actually have 5 times higher identification rate of elevated lipoprotein A if you cascade screen from patients with elevated lipoprotein A. What you can say is that if you're a clinician and you meet a patient with elevated lipoprotein A, you can be sure that a lot of the first-degree relatives to your patient that you have in front of you also will have it. So cascade screening will be an effective method to identify new patients with elevated lipoprotein A. My key message to clinicians would be initiate cascade screening if you identify one patient with elevated lipoprotein A. You will for sure have relatives, first degree and second degree, that have elevated as well. So it'll be very useful to identify new patients. We are working on looking at the efficiency of cascade screening, not just the effectiveness, but efficiency. What are the determinants of efficient cascade screening? But more broadly, I would say that we in the scientific community and we as clinicians need to start to determine the levels where we initiate cascade screening. We know it's effective, but what levels can we agree upon to initiate screening? And that's a big discussion, but I hope that we're going to do it, and I feel confident that we're going there.